Good evening, dear friends. Very warm welcome to this Cochin Ophthalmic Club continuing webinar series. And today we are having a new anti-VEGF kid on the block. And we have a very good faculty who's going to discuss about this drug. And we're also going to have some case presentations. The Cochin Ophthalmic Club has been in the forefront of academic activity even after the lockdown and the slowdown due to COVID. And we are continuing with that. Practically every week we have a CME program. And continuing in that, we have today's program. Dr. Gopal, the secretary of the Cochin Ophthalmic Club, has taken great pains to put up this program. And we also have members of the Cochin Retina Society, Dr. Mahesh, Dr. Thomas Cherian, in this group. And it's a great pleasure to welcome our two guest speakers, Dr. Anat and Dr. Aditya, to this meeting. A very, very warm welcome to all of you. And I hope all the people attending this on YouTube will definitely benefit from your wisdom regarding this launch of this new medication. So with these few words of introduction, I hand over proceedings to Dr. Mahesh Gopalakrishnan, who will now start the academic session.
Thank you, Dr. Sai. Cochin Retina Society or Cochin Retina Interest Group started in 2003, nearly 17 years back in a small setting. Now we are quite a good number of people. We meet every now and then and discuss our difficulties in medical and surgical retina cases. And it has been going on for the past 17 years. So today's program will start with our Dr. Gopal Pillai's presentation, whether to leave little fluid or the role of fluid in AMD, followed by our guest speaker, Dr. Anat Loewenstein, will be talking on the new molecule, and Dr. Aditya will be sharing his experience with brolusizumab. So over to you, Dr. Gopal. You can take over for the first.
We have three cases also at the.
After that, we have three cases also discussed. That will be discussed by the panel. So over to you, Dr. Gopal.
Thank you very much, Mahesh. Let me share my screen. I hope this screen is visible. Okay. Are you seeing the screen?
Yes, very much. Yeah.
Yes, sir. So why anatomical outcomes matter in AMD is what I'll be just setting the ball rolling for the two guest speakers to speak on. So let me say that these are my financial disclosures. And first of all, there are some unmet needs in age-related macular degeneration. We know that AMD is a leading cause of severe and irreversible central vision loss worldwide, affects 10 to 13% of adults over 65, and is #1 cause of blindness in the developed world. But in India, presently, cataract and diabetic retinopathy are the two other major causes of blindness, and AMD is actually picking up because the aging population is increasing. The prevalence is about 8.7%, and there is about 200 million cases in 2020, which is on the increase. You can see that the graph of Asia is straightforward, basically because the aging population is keeping on increasing, whereas in the other places it is almost static. So 200 million will probably increase to about 300 million by 2040, and this will significantly increase the burden of AMD. But you can see this slide, which tells that in the late 90s or in the early 2000s, when this was the blindness caused by age-related macular degeneration, by about 2006, you can see that the anti-VEGF therapy was launched, and then you can see the decline in the legal blindness, about 50% reduction in the incidence of neovascular AMD-associated legal blindness has been there. But the real-world studies are in sharp contradistinction to the clinical trials, where in clinical trials, in most of the clinical trials, there were 10 plus injections per year, whereas in the real-world studies, there were about 4, 5, 6, or 7 injections in different regions, and the visual gains are like 3, 2, 6, and 7. So this is the real world statistics as a part of clinical trials. And if you look at long-term visual maintenance, it is very important to find that visual maintenance is directly related to the treatment intensity. More the number of injections per year, and year after year, unlike in diabetic macular edema or in some of the other conditions in AMD, because it is basically secondary to aging, and aging doesn't have a cure, probably the number of injections that you require is keeping on to be on that particular platform. And what happens is, like, this is UK, 9 injections in 2 years, the Netherlands 8.7, Germany 5.6 in 2 years. So this is what is happening. And so after the initial spurt increase in visual acuity, it stabilizes for a long period of time, and then slowly it will keep on falling, especially if the number of injections are like 5 and 6 and 5. You can see that the visual acuity actually falls below the baseline visual acuity. So compared to clinical trials where there is a significant improvement in vision up to about 10 letters or 12 letters over a long period of time, in the real world, by the second year, third year, there is a lot of problems. And even the physician had a lot of unmet needs. And according to the PAT survey of 2018, they said reduced treatment burden requires improved efficacy. They required a long-acting sustained delivery systems and newer mechanisms of action. And this is what the physicians wanted. About the patients also, the treatment and the monitoring burden can actually lead to under-treatment, because one is stressed clinic capacity. The other thing is basically because the patient results in increasing monitoring burden. Patient requires to come again and again and again. Slowly, what happens is there will be delays and there will be loss to follow-up type of patients which are increasing. So here is one patient. It is not possible to predict disease activation, reactivation, when extending the treatment intervals. In clinical trial setting, even when we are moving into a treat and extend format, there will be a regular follow-up of the patients at least every 3 months. You can see that after 3 months to 5 months, there is about 65 to 70% recurrence rate. And in the real life situation, when we are doing a treat and extend, many times the patient come back after 4 months or 5 months. They want to increase the duration further. And thus it is not possible to predict disease reactivation. And many times the patient comes back when there is a recurrence of bleed. Even though we tell them about all this, they will come like that. And that is a problem that we all are facing. Now, despite neovascular AMD being a chronic disease, and all of us do take a lot of time to explain to the patient about the need for re-injections, many patients discontinue anti-VEGF therapy by about the average, the median is about 3.7 years. And the reasons for discontinuation probably in our setting would be, one, financial strain for the patient. Number two, patient does not have any bystander to bring every time when they are coming. Number three, they would be thinking that the visual acuity is not improving proportionate to the payment that they are making. Number four, they have the perception that vision is not improving, or actually vision is deteriorating. So all those perceptions are there, especially in the first eye. When they lose the first eye and when they have a problem to the second eye, the patient compliance significantly increase. Now let us come to the crux of the problem, the retinal fluid and its detection in AMD. In the CAT trial, they showed that 80% of the eyes had fluid involved in the foveal center, and SRF was the most common, the subretinal fluid, which is about 80%. Intraretinal fluid was seen about 75%, and sub-RPE fluid was found in about 50% of the patients. The time domain OCT was the original OCT technology, which actually gave us some input, but now with the spectral and the swept source and even the OCT angiography, we are able to actually pick up a lot more fluids because the resolution of picking up any finding is significantly better. The future is about home-based OCTs and artificial intelligence algorithm. Now let us come to the different type of fluid. All fluid in that retinal area, the macular area, is considered pathological, be it intraretinal fluid, subretinal fluid, or sub-RP fluid. Examples of intraretinal fluid would include cysts like this, or intraretinal edema, just edema or cystoid macular edema, or even retinal exudates or retinal hemorrhages or intraretinal hemorrhages. That is intraretinal fluid. And subretinal fluid would be below the sensory neural retina, but on top of the retinal pigment epithelium. So in that subretinal space, if there is fluid, then that is called subretinal fluid. It's serous retinal detachment or macular detachment. It can be hemorrhagic retinal or macular detachment, subretinal hemorrhage, subretinal exudates. All these are subretinal fluids. And sub-RPE is below the RPE in a type 1 choroidal neovascular membrane or something like that. So sub-RPE hemorrhages can be there, pigment epithelial detachment, fibrovascular or serous, or hemorrhagic RPE detachment can be there. So intraretinal fluid, subretinal fluid, and sub-RPE fluid, all of these are pathological. Now the clinical relevance is one for diagnosis. Presence of intraretinal fluid and subretinal fluid are markers to diagnosis. Now, once you diagnose, now fluid is there for a shorter period of time, you have a better visual outcome. Fluid is there for a very long period of time before you start treatment, the visual outcomes are slightly poorer. Now, what about disease activity? Disease activity almost always is about presence or increase in the fluid in any of these compartments. Again, visual outcomes, rapid retreatment of AMD whenever you are seeing an AMD for a long period of time is present on the fluid, and the treatment interval also depends on the rapid recurrence or reappearance of fluid. If you see all the trials in AMD, fluid is a key retreatment criteria. In all these trials, CAT, EVAN, Harbour, Lucas, View, all these trials, you can see any fluid on OCT, any SRF, any fluid on OCT, any evidence of disease activity, which means fluid, any fluid. So this is the retreatment criteria. So whenever there was any fluid, or later we in the fluid study and all, we tried to tolerate some element of fluid, but any fluid generally is activity. Now, if you want to treat that or not to treat that, I think the future, we will basically come to that. Now, this is a pair post-hoc analysis. So here you can see that in 5 months, we did an OCT, and the blue line represents those patients in whom macula was dry by month 5. And the red line denotes those patients in whom macula showed fluid at month 5. You can see the difference, plus 3.86 letters versus minus 3.24. The difference is about 7 or 8 letters. So that is a difference when you have fluid and you do not have fluid at month 5. Similarly, at month 8, if you had fluid or if you did not have fluid, blue showed no fluid on the OCT. You can see plus 5.5 at the 24-month interval and minus 4.4 here. Here, the difference is also about 10 letters. And that is the difference if you have fluid on the OCT versus no fluid on the OCT. Now, Saylor and Harbour gives us a very good idea about the PRN treatment. So this is the Saylor PRN group, and this is the Harbour PRN group. In the Saylor PRN group, the retreatment criteria was set as more than 5-letter decrease of vision, which is the same as that in Harbour, 5-letter decrease of vision. But here, in order to re-inject, the other second criteria was increase in 100 microns of central foveal thickness on a time domain OCT, whereas here it was any evidence of disease activity in SD-OCT. So here, any evidence of disease activity, we would re-inject, and here only if it increased to 100 microns or more, and it was a time domain OCT, that is when you re-injected. You can see that after the initial improvement in visual acuity after the initial dosages, you can see the steady decrease in the visual acuity in the Saylor as compared to maintenance of that in the Harbour study, which tells us that detection of any fluid in the OCT in the PRN treatment arm definitely benefits the final visual outcome. So what is the importance of intraretinal fluid? So intraretinal fluid is, in the sensor neural retina, if there is cysts or, small hemorrhages or exudates or small edema. Intraretinal fluid can accumulate in well-defined spaces called cysts. Presence of intraretinal fluid at baseline is a negative impact in BCVA. Both residual or new intraretinal fluid is associated with more worse visual acuity. Most of the type 2 CNVMs, which are the classic CNVMs, and also the more chronic occult CNVMs will have these intraretinal fluids. And I have found personally that if you do not treat intraretinal fluids for a long period of time because of any reason, there is a higher possibility of it to bleed. What is the important subretinal fluid with neovascular AMD? The presence of subretinal fluid at baseline in some studies were associated with better outcomes, and some studies, especially if there is a recurrence of subretinal fluid, was associated with worse outcomes. I would like to mention at this point of time the fluid study in which about 50 microns of subretinal fluid is tried to be tolerated so as to reduce the final development of geographic atrophy or other things like that. But you should understand that that study also very tightly monitored these patients. And even if there is a slight increase in the fluid, they were re-injected. So tolerance of fluid should not be to the levels to say that the patient will bleed and come back to you. What about sub-RPE fluid? I have found that sub-RPE fluid or pigment epithelial detachment is more well tolerated. It's an activity of the type 1 CNVM, a buildup of fluid between the RPE and the Brooks membrane. And a small number of studies only have investigated the importance. And till the point of time when aflibercept came in, we usually, with multiple injections of ranibizumab or bevacizumab, we did not see so much of improvement with the pigment epithelial detachment, but with aflibercept, actually, it has come down, and we are eagerly awaiting as to how that would be in the newer drug brolusizumab. Now, what about the central subfield thickness variability data? So there is increased retinal thickness and fluid on the OCT. In any space of the retina, basically there is activity, and so we give an injection. So the question here is, do fluctuations in retinal thickness have an effect on visual outcomes? Now let us look at the CAT and the EVAN trials, in which they looked at, they actually categorized these patients into 4 groups. One group, group 1, was no fluctuation in central subfield thickness after completion of the loading dose. You can see that there's a lot of activity here, which is significantly reduced. But after that, there is no significant change in the fluid or the thickness. Whereas here, there was minor fluctuations. Here, there was moderate fluctuation between these 3. And here, with injections, it initially reduced, but then there was major marked fluctuations. Okay, these were the 4 groups. And similar to this, in the hawken harrier, which I think Dr. Anat is going to present to us, again, we divided into 4 groups: less than 27 micron change, 27 to 44 micrometers change, 44 to 68, and more than 68. So these were the 4 groups based on the central subfield thickness variability, and we analyzed them. And you can see that at this, the first thing, the visual acuity is here. As the variability kept on increasing, you can see the visual acuity also kept on decreasing in the hawken harrier as well as the CAT and the IVAN. So this is the visual acuity data of the 4th group on the hawken harrier. You can see that 10.3 letters in the first group where the variability was minimum, and you can see only 2.1 letters by 96 weeks in the arm where the variability was maximum, more than 68 microns of change in the central subfield thickness. So what is the correlation between fluid presence and CST variability? Yes, again, in the hawken harrier pool data, they were divided into 8 microns, 8 to 17, 17 to 38, and more than 38. And you can see that as the groups progressed, actually the mean fraction of visits in which there were intraretinal fluid or subretinal fluid increased. So whenever there was subretinal fluid or intraretinal fluid, the variability actually increased, and they had a direct correlation. So the pool data shows that the results show that they are consistent with the findings of the CAT and IVAN. And although the amplitude of the visual acuity gain is an individual basis, but more stable central subfield thickness, that means a better disease control, is always associated with better visual outcomes. Okay, and that is associated with sustainable fluid-free retina, and that is our anatomical objective of treatment. Now, these we were talking about clinical trial situations. Now, Dr. Usha Chakrabarti basically published this particular thing, association between visual acuity, lesion activity markers, retreatment decisions in neovascular AMD, and that gives us an insight into the overall real-world statistics. Okay, this study, basically the association between OCT markers of lesion activity, which is basically the types of fluid, etc., and the changes in visual acuity, and how does the visual acuity and OCT markers were used in patients' decision to retreat. So these were the things that we had to do, and it was a retrospective, non-comparative, non-randomized cohort, about 1,200 patients. The primary objective was to look at the first 3 months, OCT marker, what is happening, and then the maintenance phase, what is happening between 3 and 12, and change in visual acuity from baseline to month 12. And the secondary objective was to evaluate how the patient recorded measures of visual acuity and OCT markers of activity actually influence the decisions to retreat. Now you can see that this is the number of visits with the intraretinal fluid was absent as you go from left to right. And this is the visual gain. So you can see that as the intraretinal fluid was absent, you can see that the visual gain was increasing, as was it in subretinal fluid. If subretinal fluid was absent in these visits, the visual acuity started increasing. So now some of the OCT markers of lesion activity, which the physicians thought were very important in managing with an injection. You can see that here, an intraretinal fluid or a subretinal fluid, if it is present, it finally realized in about 5 times or 6 times the number of injections than the other things. So presence of retinal fluid would mean that 5 or 6 times those patients would undergo a treatment. So the study confirms the association with presence of intraretinal fluid or subretinal fluid in clinic visits, and physicians are basing their decisions to inject not only on visual acuity guidelines, but also on the presence of fluid. And retreatment decision making most strongly influenced by the presence of intraretinal fluid and subretinal fluid. So the real world statistics in UK is like that, in which there are 9 injections in 2 years, but in the other places where the number of injections are like 5 or 6, or even in India where it is about 4 injections in about 2 years, probably if you take the whole India combined, the tolerance of intraretinal fluid and subretinal fluid will definitely worsen the visual acuity. So in a nutshell, all retinal fluid is considered a disease, activity, and more stable central subfield thickness is associated with better visual outcomes. A stable central subfield thickness was associated with a sustainable fluid-free macula, and retreatment decisions are based on intraretinal and subretinal fluid. We would like to see the newer drugs, whether we are able to give this anatomical conclusions in terms of better visual outcomes. Thank you very much. Over to you, Mahesh.
Yeah. Thanks, Gopal, for that outline. We all do practice based on a lot of factors day-to-day practice based on a lot of factors, not only the fluid, the economic conditions, and a lot of other factors are there. So all of us used to leave little fluid, but as you said, in long term, they are all going to they are going to worsen gradually, even though the rapidity with which they worsen is not very fast. So I will, you can, any other point for discussion, Gopal? It is muted.
We will have the 3 talks and then have the discussion. I would request Dr. Thomas Cherian, who is the head of Little Flower Hospital, Angamali, to introduce Dr. Anat.
Good evening, Honorable COC President Dr. Sai Kumar, dignitaries. It's my privilege and honor to introduce Professor Anat Loewenstein to this august audience. Professor Anat Loewenstein is Chair of the Ophthalmology Division at the Tel Aviv Medical Center and full Professor of Ophthalmology, incumbent of the Sidney A. Fox Chair in Ophthalmology and Vice Dean of the Faculty of Medicine at Tel Aviv University in Israel. She's a well-known clinician and scientist in the field of retinal disease. Professor Loewenstein also carries multiple international leadership positions. She is the General Secretary of the EURETINA Board, is a member of the International Committee in the Macular Society Board, and was recently granted a chair in the Academia Ophthalmologica Internationalis. She received many honorable awards, including the Rosenthal Award and the Pats Medal of the Macular Society. In addition, she also serves on multiple retinal advisory boards. Professor Loewenstein's main area of expertise are AMD, including early detection and automated technology for CNV detection, retinal vein occlusions, and the investigation of drug toxicity to the retina. She is the author of 300 publications in peer-reviewed journals, multiple chapters in books, as well as textbooks in ophthalmology, and serves on several editorial boards, in addition to being the editor of case reports in ophthalmology. To put it in a nutshell, Professor Anat Loewenstein is the all-in-all of medical retina. Welcome, Professor Loewenstein.
Thank you very much. It's a great honor to be here. I'm thrilled to be here. I'm so happy. I am participating in this meeting after I came urgently to the United States last night because I have a new addition to my family, and let me share my screen with you. Here. Okay. So I just wanted to show you the new addition to my family that came yesterday, a grandson, and I came here to take care of my older granddaughter. So without further ado, we'll continue with brolusizumab. Can you see my screen, everyone?
Yes, please.
Okay, I will talk about brolusizumab, its indication, results in trials, and problems and precautions. I think it was fascinating to hear the previous talk and to understand the importance of fluid, and I will be glad to show you how brolusizumab copes with that. These are my financial disclosures. And I think we saw in very detail in the previous talk how important is fluid in the management and in the understanding of retinal disease. I don't need to tell this audience that fluid damages the retinal structure, and it is a major concern in the progression of neovascular macular degeneration. And we are talking about damage that it can do to the retina by displacement of the photoreceptors, accumulation in all retinal layers due to this disorganized leaking blood vessels. We know from many trials that resolving the retinal fluid is the most important thing in neovascular macular degeneration management. So I'm introducing to you brolusizumab. Brolusizumab is the smallest known active unit of an antibody that allows for concentrated molar dosing. You can see here that the molecular weight is only 26 kilodalton. It's a single chain antibody fragment for which the clinical dose is 6 milligrams in the clinic and in the pivotal trials. So definitely you can put into the eye in one injection a much higher molar dose than you can with the other drugs, as you can see on this table. The reason that we are able to use brolusizumab for the management of AMD is the result of the successful results of the hawken harrier pivotal trials that were trials that aim to assess the efficacy and safety of brolusizumab versus aflibercept in patients with neovascular macular degeneration. In this trial, patients received brolusizumab and were compared to aflibercept that were given in the standard according to the label, because you always have to compare to the label. And patients were treated with brolusizumab in which arms patients could be treated every 12 weeks. If they showed disease activity, then the interval was reduced to 8 weeks and remained 8 weeks for the duration of the trial. Overall, brolusizumab achieved superior reduction in central subfold thickness as compared to baseline to week 48 that were sustained through week 96 as compared to the comparator aflibercept. As you can see, both in the hawk and in the harrier, at every single time point, the mean change of central retinal thickness was higher for brolusizumab as compared to the comparator aflibercept, and the differences were statistically significant. There were a few time points that were very fair by way that they showed a very accurate comparison. For example, week 16 was a time where all the patients were at the same time interval following the last injection. And as you can see here, patients that received aflibercept plotted in the gray columns, both in the hawk and in the harrier, had a higher percentage of patients that showed disease activity by way of intraretinal fluid and or subretinal fluid as compared to both arms of brolusizumab. So at this very fair point of comparison, it is evident that brolusizumab is more active by the way that less patients show disease activity at week 16. So that was at week 16. the data was analyzed in multiple additional ways. For example, the time and number of injections that were required for 50% of the treated patients to achieve sustained fluid resolution was investigated. And as you can see on these Kaplan-Meier curves, this time, both the time and the number of injections, both at the hawk and at the harrier, were in favor of brolusizumab as compared to aflibercept, the comparator. Same results were seen when the time and number of injection required for more than 70% of the eyes of the treated patients to achieve sustained fluid resolution. Again, as you can see in the survival curves, the results were better for brolusizumab as compared to aflibercept. Another question that was dealt with some post-hoc analysis was the question of difference in treatment outcome in patients with early persistent fluid. It was again a post-hoc analysis. You can see on the graph on the left that there were a percent of patients that had early persistent retinal fluid. This percentage was higher for patients treated with aflibercept as compared to the patients treated with brolusizumab. There weren't any statistically significant difference in the baseline between these groups of patients. And when you look at the mean change in best corrected visual acuity over 96 weeks in patients with early persistent fluid, you can see that the patients treated with brolusizumab had better visual acuity outcomes at the end of 96 weeks as compared to the eyes treated with aflibercept. Similarly, when you look at the mean change in central subfield thickness, again, the results were in favor of brolusizumab, also in this post-hoc analysis. So in the meantime, I showed you that brolusizumab, when given every 12 weeks, or even when, or if it, in the cases that needed to lower the interval to 8 weeks, provided comparable best-corrected visual acuity gains to aflibercept with superior anatomical outcomes. Brolusizumab provided sustained fluid resolution rapidly with a mean number of injections of 3.3 and 2.6 in hawken harrier respectively, with over 75% of the patients achieving sustained fluid resolution according to a post-hoc analysis. Patients with brolusizumab with early persistent retinal fluid did have robust vision gains at week 48 that were maintained to week 96, with notable central subfield thickness reductions, again, according to a post-hoc analysis. So we all know about the safety profile issues that came along with already in the trial, and especially when the trial started to be, when the drug started to be used post-registration. Altogether, when you look at the results of the trials, when you look at the percentage of patients that had more than one adverse event, ocular versus non-ocular, the numbers were pretty similar among the groups. When you look at serious adverse events, well, for serious adverse events, it seems that the percentage of serious adverse events for brolusizumab was somewhat higher than that of aflibercept, but when you look at the patient, and this is a very important point, when you look at the percentage of patients with more than 3-line 15-letter vision loss or equal to 15-letter vision loss at week 96, the percentage was very similar between the brolusizumab treated eyes and the aflibercept treated eyes in both trials, the hawk and the harrier. Here you can see some more data on the ocular safety profile. So again, I'm showing you the same result that I showed you before, that there was a higher percentage of patients treated with brolusizumab that had a ocular serious adverse event as compared to aflibercept. Let's drill down into the adverse events, specifically the ones that may be relevant to intravitreal anti-VEGF. Let's look at intraocular inflammation, at retinal artery occlusion, and at endophthalmitis. As you can see here, these percentages were higher for brolusizumab as compared to aflibercept. That was true in hawk and was also true in harrier. It's important to look at the incidence of these events. So inflammation about 4%, artery occlusion and endophthalmitis in about 1%. This is higher than in the group of aflibercept. However, again, when you look at patients with 3-line, 15-letter or more vision loss, the numbers were similar between brolusizumab and aflibercept, both for 15-letter and 30-letter, both in hawk and both in harrier. If you want to drill down a little bit more into the very concerning issue of inflammatory events, following the safety committee, the safety review committee for this unwanted side effect, these are the numbers in total. 50 patients out of the 1,088, which means 4.6%, developed intraocular inflammation. 36 of them, 3.3%, developed vasculitis. And 23 of them, 2.1%, had some level of retinal vascular occlusion. The overall risk of developing at least moderate vision loss among these patients was 0.7 or 0.6. Another important point is that most inflammatory reactions occurred more frequently in the first 6 months, 74%, following the first dose. So it seems as time goes by, there is less a tendency of the inflammatory process. The company developed, together with the safety committee and a group of experts, recommendations for the management of intraocular inflammation. So in case of intraocular inflammation, when the most important thing is to rule out endophthalmitis and then to start intensive treatment based on usually topical steroids and to monitor the patients regularly. If there are signs of vasculitis, you need to try and document it by ultra-wide field imaging, and again, use potent topical, intravitreal or systemic steroids and continue the monitoring. And of course, if there is a retinal vascular occlusion, in this case, you of course need to document the case and use steroids and long-term monitor the patients. So there are some approaches to treat these cases of intraocular inflammation. We are dealing with spontaneous reports on the use of brolusizumab in AMD that revealed a clinical spectrum of intraocular inflammation, retinal vasculitis, and vascular occlusion, which are of concern. There are recommendations on how to treat this situation. The company embarked on a very intensive program to try and understand where did this safety issue come from, who are the prone patients to that, how to try and identify them, and how to treat these patients. It seems that due to the excellent efficacy profile and the relatively low number of serious decrease in visual acuity cases, brolusizumab is an important treatment option for patients with neovascular macular degeneration. I would like to show you a few cases of Professor Vas Sada from the United States. We still don't have brolusizumab in Israel out of the trials. We did participate in all the trials. This patient had multiple ranibizumab and aflibercept injections in a 4 to 6 intervals and still had all the time subretinal fluid. You can see how it dries nicely after 1 injection of brolusizumab. And this holds for a pretty long time. He's treated by more injections of brolusizumab. And now he's completely dry with a 4 to 6 time interval. This is a lady that, again, gets frequent anti-VEGF injections every 4 to 6 weeks. She's treated by brolusizumab, and it's the first time that she is actually completely dry. After a 6 weeks interval, she again has fluid. 72-year gentleman treated by aflibercept and doesn't respond in a well enough manner after many injections, treated by brolusizumab, is doing well. Another brolusizumab, doing well. So after the switch, is treated with 4 to 8 week interval. 88-year-old person that had a very protracted intraocular history, treated with aflibercept, doesn't respond, significant cystoid macular edema, intraretinal fluid, more aflibercept, not good, well enough response. And now he's getting brolusizumab, a nice response, a good improvement in visual acuity. A 69-year-old lady with neovascularization, diagnosed, treated by aflibercept 14 times, not a good enough response, gets brolusizumab and has a good response that holds for a long time. You can see here a comparison of the treatment response to brolusizumab on the right-hand side as compared to aflibercept on the left-hand side. There were also some successful cases with PCV. This is a Japanese male with PCV. Gets aflibercept, many injections, not a good enough response. Suspicion to have a polyp. Gets brolusizumab. And even this very complicated case has a good response. Just to show you that the drug is very effective and we need to consider and learn how to use it, albeit the existence of the intraocular inflammation that is definitely of concern and that we definitely need to try and diagnose early, monitor and treat if needed. Thank you for your attention.
Thank you very much, Anat. Dr. Mahesh?
Should we have discussion now itself?
Let Aditya also finish his case, no? Then we will have a panel discussion.
Okay,
so, Thomas,
then we have a lot of questions because it's the beginning of a new era probably. So
in the YouTube, I will look at the YouTube and see if there are any questions and post it here.
I don't think there is any. I was just looking at it.
Okay, I will do. Okay.
Yeah.
So can I share my screen?
Sure. Thomas, you can introduce. Yeah.
Before that, let me introduce Dr. Aditya Sudhalka, a vitreoretinal surgeon who practices in Germany as well as in Baroda. Aditya has 9 years of experience in vitreoretinal surgery, have co-authored 32 publications, 20 as first author and 27 as corresponding author. His areas of interest are diabetic macular edema, tractional retinal detachments, and endophthalmitis. He has authored a book on minimal surgery for retinal detachment. Aditya currently holds the position of consultant vitreoretinal surgeon, Alpha Vision Internationalis, Augenzentrum, Bremerhaven, Germany. And he is a consultant in vitreoretinal surgery at Sudhalka Eye Hospital and Retina Center in Baroda, as well as in Rakudi Eye Hospital, Ahmedabad, India. He has numerous awards to his credit. He has numerous presentations and publications. And Aditya, we look forward to hearing from you, your experience. Please.
Thomas, Aditya just called. His laptop just hung, and so he is just going out and coming back. So in the meantime, Mahesh, we can have 2 minutes of question time to Anat.
So actually, whenever we start a new drug, we are worried about all the adverse events first and then the effect. I have a couple of queries. If it is acting for a long time, why do we need monthly loading initially? Why it is because the maintenance dose and all, it is Q12. So why do we need the initial monthly dose? I am asking this question in the setting that initial doses are likely to cause more adverse events like vasculitis, especially in that evidence. So can we do away with that monthly dose initially?
I think it makes a lot of sense, Dr. Mahesh, what you are saying. I think it's actually very reasonable. I think that in the study, it was compared with the loading dose because you need to compare to a label. Okay. And if the company would have not given the loading dose, they would have already a disadvantages compared to aflibercept. So why should they do it, you know? So that would put them in an inferiority position as compared to aflibercept. So therefore, I think it was the reason in the study. But Actually, what you say makes a lot of sense. And maybe one thing to do is to recommend to them, to Novartis, an investigator-driven trial that will not do a loading dose. Maybe in this situation, they will have less of inflammation.
Yeah.
So I think it makes a lot of sense. Let's do it.
Yeah.
We can do it in collaboration.
Yeah, we have, yeah, definitely. The one more thing I was not regarding this systemic adverse event. We are injecting quite a high dose of 6 milligram. So now there are a lot of talk among nephrologists, like after that article that was published in Kidney International, a lot of people are asking whether it will worsen nephropathy, the renal toxicity. So are we expecting more systemic adverse event because of the higher dose of 6 milligram, and probably the systemic absorption is more and the adverse events can also be more? So can we expect such a problem? Yeah.
So actually, there wasn't a signal in the trials. No problem with any blood tests or anything. And I think I'm not a good enough pharmacologist to tell you, but I think the fact that it's very small, even though it is absorbed into the systemic circulation, it is also cleared pretty fast. Okay. So even though you are right, because the high, the 6 milligram, which is a lot, and the small weight brings along, how can I say, a large molar load or molar load actually, but such a signal has not been seen to date.
Right. Gopal, I think Dr. Aditya is ready. We can go ahead with that, and then we'll come back for the discussion.
Yeah, so good evening, everyone, and my sincere apologies for this mix-up. I don't know what happened. The computer just hung up. So without further ado, I will just go to my presentation. These are just pictures from my clinic in Germany. We'll go to the first case, and this was a 74-year-old retired physician from the land of Bremen, the state of Bremen in Germany, presented to us with metamorphopsia since 4 days and diminished reading ability. So his vision in the right eye was fine, but in the left eye it was 6, 12, and 10. They use the decimal system, but I'm going to use the Snellen chart for ready reference. The anterior segment was unremarkable except for the presence of pseudophakia. The IOP was fine. So this is what the angiographic pictures look like. And beginning 28th of November 2018 until March 2020, he continued to, these are just raster scans of the same patient. He received 6 consecutive aflibercept injections as per the German protocol. That is 1 injection per month for 6 consecutive injections. And then if the macula remains dry, then you can go ahead and increase the treatment interval by 2 weekly spurs. So basically the treat and extend protocol is the standard of care in Germany for all macular diseases involving macular edema. So as we see that despite a regular therapy with aflibercept, the disease continued to progress. So in March, he was switched to brolusizumab. He responded very well. Currently, he enjoys very good vision. And this is after the first brolusizumab injection, and this is after the second injection. So now, as per the German protocol, if a patient is already under therapy, you don't need to complete the mandatory 3 injections after switching. You can take a call after each injection. So in this case, he was followed up. This is after 12 weeks. So at the 8-week follow-up, he was fine. We see some early recurrence here. So he received a 3rd injection, and he has been maintaining this ever since. So this, going to the second case, this was a 78-year-old lady who was a Jehovah's Witness. Basically, one of their tasks is to go to people and read the Bible with them, just explaining all the intricacies of the Bible with them. So essentially a lot of reading. And she complained of missing letters in the Bible since 7 days. So again, she had metamorphopsia, but reasonably good vision in spite of the metamorphopsia. And she had a very small CNV. In fact, the angiography in the initial scans left room for doubt as to whether there was any CNVM at all. But the raster scan did show some changes. So in this case, we decided to directly go ahead with a brolusizumab injection. So she responded very well to the first injection. But as is the rule now, instead of 6 injections monthly, for brolusizumab, the German protocol is 3 monthly injections followed by treat and extend or PRN as per the surgeon's wishes. So now she has good vision, and she has had a 6-month follow-up from the day of from baseline, and she's doing fine. So this is just a reiteration of whatever I said. So this was a 69-year-old Arab lady who again presented to us with an inability to pray, that is, read the Quran. And this is what the fundus pictures look like. So this is the OCT scan, evident membrane subretinal fluid, intraretinal cyst thickening. Responded very well to 1 injection, but of course there was some residual fluid. So she received a 2nd and a 3rd. So she responded with the 2nd itself, but as per the protocol, she got the 3rd injection. And she again has been doing very well for the past 6 months. So this is just a summary of patients. There are 25 patients now in our clinic who have completed a 6-month follow-up. The data here is more or less in line with what we would expect to see with brolusizumab. But I think the biggest thing, or the biggest concern that everybody had, is this: that is, there is no report of inflammation or vasculitis either from our hospital or from any of the other hospitals in Germany, because they have a very good information sharing system. We haven't had any word, at least, of there being any advisory on the use of brolusizumab thus far. So we have had occasion to use brolusizumab last week in India itself, and it was obviously a patient of switch therapy. So he first presented to us in April 2017 with a complaint of metamorphopsia. He had had recent cataract surgery, and along with decreased vision, although the vision officially was 6/9 N6, but the Amsler reading was positive. Now his angiography, OCT and OCT angio was done elsewhere. So what I've actually done is just put up scanned copies of his pictures. I apologize for the poor quality of the images. And keeping in mind that this happened 15 days after the cataract surgery, we suspected the role of inflammation in this particular case. Now, before I go to his left eye images, that is where the problem lies, I just wanted to show the right eye as well, because the right eye shows waxing and waning fluid, as you can see here, but he is asymptomatic. His vision is 6/6. So this fluid keeps coming and going, and it is possible that he had pre-existing disease which was exacerbated by the cataract surgery, and since then he has been on therapy with us. The other issue with this patient is that he travels a lot, and he spends about 4 months in 3 different continents. So it's like Asia, Europe, and the US, which means that his treatment has not only been fragmented, it has been very inconsistent. Notwithstanding, he has received, as I've already mentioned here, 23 injections overall before he received his brolusizumab, including 1 Ozurdex. So what we see is that despite injections, the fluid continues to worsen. So I only have the scans that he, during his visits to India, but there was really no response until we convinced him. So he was very apprehensive about injecting steroids. We even tried posterior subtene and triamcinolone. It did not show any effect. So what ultimately worked in this patient before switching to brolusizumab was a combination of Ozurdex, and you can see the implant here, with Eylea. So this lasted for 2 or 3 months, and then he came back with this. At this point in time, we injected brolusizumab, and it's only been a week. But I think we injected last Saturday, and this is what it looks like today. So I also have a central fundus photo from today. The periphery, we examined the periphery. There is no evidence of vasculitis thus far. But I think from what we see from reports, we have to wait for 4 to 8 weeks before actually declaring that there is no vasculitis or that the patient will not suffer from vasculitis. So thank you very much. This was just a quick run through to get everybody oriented to the use of brolusizumab. And I hope my presentation was useful. Thank you.
Thank you, Dr. Aditya. Nice cases.
Excellent cases.
Thank you, madam. Thank you, sir.
So we'll have a discussion on all aspects of use of brolusizumab. One other, the previous, any comments for the cases, Gopal? The last case that you showed, Aditya, did the patient have angioid streaks?
He did not, sir. Actually, we repeated his ICG as well, and we didn't see any polyps.
He had a broad VMT though.
VMT was there towards the end.
Yeah.
But,
broad.
And he also has a developing ERM, I think, because of the persistent inflammation.
No, because most of the findings were between the disc and the fovea. And
Yes.
It was nasal, yes.
Yeah. So I was just thinking
nasal.
whether that
Even the PD, I had put in one photo of the PD that was very nasal. I mean, that was just above the disc. So I don't know if it was a
peripapillary pachychoroid or
yes.
something.
Yes.
Okay. Yeah, that is why the recurrence is quite bad in many of these.
All the scans, sir, because he spends in UK and Canada, and they've been continuing with Eylea. But we told him from the word go that this is probably an inflammatory. I mean, the chronology of events suggested that the cataract surgery set off a pre-existing lesion, or rather exacerbated a pre-existing lesion. So ultimately, what actually worked was the Ozurdex implant combined with Eylea. And then we've told, we've given him a note that this is what had worked. He will be now following up in the UK because he's due to leave on 15th. So, but this brolusizumab, in a week's time, the fluid has definitely come down. His vision has never been, ever since the last year, I think his vision has never improved beyond 636. But like Gopal sir's, presentation, anatomical response is also equally important. So even like vision alone.
Yeah. Thank you. What is, Dr. Anat, what is your take on this? See, on one side, we are telling too much drying will cause geographic atrophy. There are studies and supportive evidence. And here we are telling brolusizumab causes better drying. So how do you balance these two?
I'll tell you, I don't think we have enough evidence to say that drying causes the geographic atrophy. I think it's one thing to say that subretinal fluid is not as harmful as intraretinal fluid. I agree to that. But I think it's very dangerous to conclude that you need to leave some subretinal fluid. I think we don't have enough evidence for that. There are very small studies that did show some trend, but I don't think they are good enough. And I think it's dangerous to conclude that you have to leave subretinal fluid. I'm not saying if I have subretinal fluid that is stable, I don't necessarily chase it to the last drop. Yeah. But to say that I need to leave it, I think is a little bit too much.
But having said that, you would not leave any intraretinal fluid, right?
Usually I wouldn't. Usually, I also would not. Usually, I try not to leave also subretinal fluid, but I may be a little more permissive if it is stable. To tell you the truth, even intraretinal fluid, if it's very small and it's very stable, it doesn't respond, visual acuity is good, I may not chase it to the last drop. But all of it is only when you continue to follow up the patients.
We all leave fluid because of helplessness, probably, continuous injection.
Exactly.
Yeah, not that we will leave, okay, this is enough. Yeah.
To that. Exactly.
So in that, IRF is little dangerous than SMD. That's all. That is the conclusion.
Yeah, exactly. Absolutely. I totally agree.
So right now, when you have this new drug, what are your, current in your mind, what are your indications where a treatment naive person is coming to you with AMD and you're going to start them on aflibercept, ranibizumab, or brolusizumab?
Can you hear me? Because I cannot hear you now. Can you hear me?
Yeah. Gopal, you can repeat the question.
Wrong with my, let me.
Okay, so in a treatment naive patient with this new treatment, what would be our, what would be our choice? Has it made a difference?
To tell you the concerns, I think I will not start using brolusizumab on treatment naive eyes. At first, as I thought I would before the emergence of this issue. Now I will use it primarily on patients who are not responsive enough or who need many injections that never had any inflammatory reaction. Now I will not use brolusizumab on a treatment naive eye, at least not until I will gain personal experience with the drug.
Same thing we were also thinking. We will initially use it for resistant cases or which are not.
Exactly.
And with our own experience, we can modify this.
Yeah, and then we'll see what's going on. Yeah, and we'll understand who are the prone patients to get inflammation and who are not.
Right.
Do we have any evidence for brolusizumab in polyps?
Well, there wasn't any study about polyps, and the patients with polyps were excluded from the pivotal trial. But there were some cases, I showed you one case, and there are some cases that I saw that it responded very nicely. I think altogether, because it's so effective, it's effective for everything that is very active.
Yeah.
Because of the small size of the molecule, probably it will penetrate a little more faster. I mean, is that the reason why there is a more faster thing? But because of the small size, will it not go into the systemic circulation a little more than the other drugs?
Well, actually, this question was asked, and I think that it probably does go fast to the systemic circulation, but it's cleared very fast, and there wasn't any systemic safety signal in the trials or in the post-marketing cases.
Do you give post-injection topical steroids in all cases of brolusizumab at present?
No, I
only
wouldn't. I wouldn't at first. Only if you develop inflammation.
Okay. It's not a blanket steroid after.
No.
Right. Gopal, any other questions?
No, so in the patients in whom, so what is the opinion regarding diabetic macular edema or retinal vein occlusion? So right now we will not start, but probably a lot of patients requiring multiple injections. The burden in diabetes is also significantly high because they are all having a lot of other treatments. So if we are having something in which we can space it.
Yeah, I think I will not run to do it, especially because sometimes they have more inflammation, these patients, but until we have the results of the trials. But, in a patient that doesn't respond to anything, I'm not saying that I will never try and use it. But it will not be my first choice.
Okay, there is a question here from Dr. Remya. Do we have any evidence which group had more adverse effects, the treatment naive or the switch group? Is there any difference between those two?
No, there wasn't. There were both groups. It happened in treated naive and in switch patients. Actually, the only parameter that could predict the development of IOI was in patients that previously had inflammation from some uveitis or from aflibercept previously. Only these.
There is a question from Dr. Rajesh that basically when we give injections, we call the patient probably 3-4 days later to see whether there is any, that is our routine protocol. In this case, when should we see the patient after injection to detect an early adverse event?
It's a good question. And I think now the idea is to see them after a few days to make sure that there isn't any inflammatory reaction. But there are no exact rules about it except the questioning. It's for sure that you have to call them and see that if they are okay, if they don't have any floaters or decrease in vision, that there isn't any clear indication that you have to see them.
Usually, how fast this vasculitis sets up, if it has to happen? 5 days, 1 week, or 2 weeks?
Usually around a week, but it can go up to a month. Yeah.
Another issue is whenever the fluid rapidly reduces, there is always this risk of a RIP happening. And what was the incidence of RIP in the hawken harrier trials?
Wasn't a high incidence, and I don't think it's true. I don't think that if you have subretinal fluids resolving quickly, it causes a RIP. I've seen it. First of all, a RIP is more about the decrease in pigment epithelium detachment. But I've seen a RIP spontaneously, with treatment, without treatment, with fast resolution, with slow resolution. I'm not sure that this really brings along high chances for RIP. And we didn't see this signal in the trials.
Okay.
Sir, if I may just take a minute.
Yeah, Aditya.
Just wanted to say that in Germany, for all patients, the protocol is that if you inject today, you follow up the patient on day 1, day 7, and day 30. And on day 7, you are supposed to dilate this is irrespective of the medication used. So at least one thing is for sure that, even peripheral minor vasculitis would generally be detected as long as you do good indirect ophthalmoscopy, and that has been done. So at least from our case, I can vouch for the clinic that there is no instance of vasculitis or anything there.
Our experience usually is that even if there is an inflammation or endophthalmitis, it starts after 3-4 days, 2-3 days, because the dose injected is much less than cataract surgery. So after that initial few experiences with Avastin, we started calling the patient after 2-3 days, not the next day. Next day, that is what we follow. Gopal also.
I think it's a good idea. I think you're right, actually.
Yeah.
One day after, no one will have anything.
Yeah.
I'll tell you, if someone calls me the day after and says he has a problem, I say it's nothing, because usually it's not endophthalmitis.
Yeah.
I agree with you.
Epithelium is.
It's cornea. It's cornea. Absolutely. Absolutely. I totally agree. Yeah. Yeah.
Any other question, or can we, if there is no other questions or comments, we can go for the case presentations.
Yes, let's go.
Yeah, Dr. Ramya can share the slides. These cases may not be directly on medical retina and AMD. It can be anything in medical. So we can have inputs from our expert panel. A short case presentation for 5 minutes. Dr. Ramya is a consultant in vitreoretinal surgery in Little Flower Hospital, Angamali.
Good evening all. So I'm presenting a 60-year-old male who presented with defective vision and metamorphopsia of 2 weeks duration. His medical and surgical history was non-contributory. At presentation, the baseline visual acuity in the right eye was 6/6 N6 and the fundus was within normal limits. The left eye had a visual acuity of 6/60 with multiple serosanguinous detachments. Multiple serosanguinous detachments in subretinal fluid and submacular hemorrhage. So this was the OCT which was taken at the baseline with 6/60 vision showing subretinal hemorrhage and the serosanguinous PED. So at this point, we did ICG angiography, but then although it showed the blocked blocked sinus at the region of the hemorrhage, but it did not reveal any hotspot or polyps. So at this point of time, since the patient was having subretinal hemorrhage, we went ahead with pneumatic displacement with intravitreal C3F8 with in combination with an intravitreal bevacizumab injection. And 1 month later, another dose of bevacizumab was given. And the patient was further followed up, which showed the reduction in the submacular hemorrhage, the total displacement of the submacular hemorrhage, although the PED had shown an increase in the height. But then overall, the subretinal fluid, everything had gone on, and the patient was had improved in visual acuity to 6/24. At this point, again, we repeated the ICG angiography, which revealed the branching vascular network and the polyps, which was leaking. So we explained to them regarding the option of PDT, but then since due to financial constraints, the patient could not go ahead with this, and then he opted for a focal laser with intravitreal bevacizumab injection. So these were the course of events which happened after the focal laser and intravitreal bevacizumab. At each visit, he was injected, and then there was almost near total resolution of the fluid with 6/12 vision. And at the final follow-up visit, he was maintaining 6/6 visual acuity with complete resolution of fluid. So my questions to the panelists is, what is your experience with brolusizumab monotherapy in PCV, with special regards to the subretinal fluid resolution and the absorption of some macular hemorrhage only with the brolusizumab monotherapy? And is there any difference in the treatment protocol with brolusizumab in terms of loading dose, like what Dr. Mahesh was mentioning, and the frequency of injections?
Yeah, I think there wasn't any difference. I mean, there weren't any PCV patients in this trial, but I think it's a very effective drug, and I think we should just use it in PCV patients as well as in other neovascular AMD patients. And I think we already have some cases to show that it's quite effective in these cases. So I would use it as I use it in regular cases.
Nowadays, all cases of submacular hemorrhage with pre-retinal, involving the fovea, we do give TPA. Why was it not given? Ramya, any reasons?
Yes.
TPA not being used?
Probably expense only.
No. It is so cheaper than even Lucentis now. Now, we used to do this gas injection with anti-VEGF years back, because our series was one of the earliest published in retina. This sort of, nowadays, all cases immediately next day it will get displaced, because I think it is good that finally they did have 6x6. But sometimes what happens, the blood remains there for a longer time. It causes a bad RP damage.
But what I usually do is that in cases of fresh bleed, because this was just a 2 weeks duration and it looked more of a recent bleed. That's the reason why I did not inject TPA. I would rather inject in cases wherein it is a long-standing hemorrhage where the blood would have really clotted up. So in such cases, I do prefer TPA along with my bevacizumab injection and gas injection. Yes, obviously.
I think the question if what to do in these cases of massive subretinal hemorrhage is not solved yet. The EURetina has now given a huge grant to compare, in these cases, surgery to TPA intravitreal, to TPA subretinal, and then we'll know what will be the answer to that.
Right. Okay. We'll wait.
I think Anat has to leave now.
I'm so sorry. It was scheduled only until 10:30 my time. So, and I have another thing that I need to attend to. So I apologize, and I leave you guys. Okay. Bye bye.
Thank you very much.
Thank you very much for that. Yeah.
Thank you.
Then I can actually stop sharing. Yeah. And actually, we were also doing the same thing till few years back. Now TPA is available quite cheap.
No, I give TPA, sir, but then only in cases where
now this one, the one advantage of TPA is that under the fovea it is subretinal hemorrhage, which will easily displace. Here, without that also it got displayed. We know
Mahesh,
that.
but here, the blood was just reaching the edge of the fovea.
So what?
It is not.
If
it
you
is not really.
TPA, now, the
It
reverse
is not
was,
about injecting.
I was worrying. It would have been worrying if the hemorrhage was just above the fovea, and then we inject and make it towards the fovea. Here it is below only. So TPA, and then not even strict prone position is needed here. The other one is more worrying. If the hemorrhage was more above the fovea, whether it will come down to the fovea is the question. Anyway, this both are accepted. This thing, and another thing, I don't know whether the use of Avastin in the initial injection of drug gas itself is needed, because you are injecting too many things, and Avastin will not work with dense hemorrhage. What we can probably do is after 1 week we can give the Avastin. That is another option. I am just telling you different options I am discussing.
Sir, I would like to ask, what is your experience with a breakthrough hemorrhage, like the dense subretinal hemorrhages when you give an injection? Have you had any experience of a retinal detachment happening?
Actually, we had quite a few cases where after gas injection, if it is a massive bleed, it breaks through and then it can detach also. Probably that gas is creating more havoc inside the eye by moving around and creating some of them have been regmetanous also. 1 or 2 we have seen. And
it depends on how much gas you are injecting and how much expansion is happening.
Usually, all of us used C3F8, right?
Yeah.
Yes,
yeah, C3F8 basically because you need only 0.2 cc. The other one you need a bigger volume. So, but unfortunately, this C3F8 will stay there for 3-4 weeks, 5-6 weeks.
Yeah. Sometimes I use SF6 also. It is not that I use always C3F8.
SF6 you need little more volume. That's all.
Yeah, you need, but that volume depends upon the size of the submacular hemorrhage also.
No. Whatever be the size of submacular hemorrhage, the volume doesn't change because the arc of contact is same. So the volume is not decided based on the amount of blood in the retina. These are all standard non-expansile doses based on research on arc of contact between the gas and the
expansile gas only you will give, no? Not non-expansile.
Only expansile.
Yeah, only
expansile volume of expansile gas.
Yeah, only expansile gas. Now, what regarding the breakthrough hemorrhage, it has problems. When you have a large submacular hemorrhage and you are injecting gas, you have to tell that after 3-4 weeks you may need a surgery. That is first of all we tell, because many of them come, initially I could see this side, now I can't see anything. And this blood immediately becomes dehemoglobinized, and white, it becomes white. And sometimes if there is no PVD, you are into a soup. It is very difficult to induce PVD. All of us have seen through many of this experience. We don't know why it becomes white so fast. We don't know why there is no PVD. And even if 80-year-old patient is coming, there won't be any PVD. So there are a lot of unanswered questions. But I think you have to tell the patient that this is going to, you may need a surgery if it is a large hemorrhage.
I think let us go to the next case then.
Next case, yeah.
Thank you.
Pooja, your case is ready, Dr. Pooja?
Yes, sir. My case is ready, sir. Are you able to see my screen, sir?
Yeah.
So good evening, everyone. Today I'll be discussing about the case that is the transformer. By the end of the slides, you will know why the caption was the transformer. This is a case of a 79-year-old male who is a known case of diabetes for 34 years. His best corrected visual acuity in the right eye was 618, in the left eye 1/60. He was diagnosed case of both eye moderate NPDR with right eye CSME and left eye AMD with CNVM with vitreous hemorrhage and disciform scar. Fundus evaluation, right eye media was clear, disc normal in color and shape size margins with CDR ratio of 0.5. In the macula, we could notice multiple hemorrhages, broad hemorrhages with hard exudates. Fundus fluorescent angiography of the right eye showed hypofluorescent area that is corresponding to the hemorrhages seen clinically. Multiple hyperfluorescent areas corresponding to the microaneurysms were noted throughout the fundus fluorescent angiography. ICG showed from early, mid, and late phase a hyperfluorescent area present throughout the phase. We have noticed that there is a decrease in intensity. Autofluorescent showed hypoautofluorescent areas corresponding to the areas of hemorrhages. OCT image showed cystoid macular edema with RPE elevation. At this point of time, we planned for first injection of ranibizumab. The patient's central macular thickness was 518 microns at this point of time. Post one injection, there include a one-line improvement in vision to 612 and CMT improvement to 464 microns. The patient was given subsequent monthly injections of ranibizumab continuously for 6 months. As you can see in these images, there is an increase in the sub-RPE fluid with elevation of RPE and the PED becoming more broader. These are the OCT images from the presentations to the post 7 injections. As we can see, there is an increase in the intraretinal fluid, not much significantly decreased, along with subretinal fluid increase with elevation of RPE. At this point of time, since the patient was not responding despite injections, fundus evaluation showed multiple dot blot hemorrhages. We went ahead with fundus fluorescent angiography, and we noticed an increase in hyperfluorescent area just superior to the fovea, and we could see a CNVM pattern with well-defined hyperfluorescent areas. Autofluorescent image showed hypoautofluorescent area increasing in the foveal area. OCT image showed increase in the fluid along with sub-RPE fluid elevation. Due to financial constraints, the patient was planned for Avastin. Post one injection of Avastin, the intraretinal fluid decreased. However, the subretinal fluid PED is increasing in size. This is status post 5 intravitreal Avastin injections. This is the present status of the patient with vision being stable at 612, post 29 injections of intravitreal Avastin. As we have seen in the OCT images, there is an increase in the size of PED and change in the type of PED during monthly anti-VEGF injection for diabetic macular edema. The patient who presented to us initially as diabetic macular edema developed CNVM despite multiple injections of anti-VEGF. My questions to the panelists are, even though the patient started as DME, the treatment has been anti-VEGFs, still the patient developed CNVM. Can you hear me, sir?
Yeah.
Yeah, you can stop sharing.
Yes,
Pooja.
sir.
Yeah.
Yes.
Actually, in the initial picture result, there was a PED, no?
PED was noted, sir, corresponding to the site
Before starting treatment
yes,
for
sir.
DME.
Yes, sir. PED was there, sir.
Now, all of us have seen some case of PCV, which is not responding to our routine Avastin and Axenrix. We all of us have seen some of the PEDs will keep on increasing. In fact, some of the OCTs that you showed, there is that flat irregular PED, the lateral expansion of that. That is typical in BVN with PCV. Actually, it is not that after Avastin it developed PCV, but it is a non-responsive PCV worsening with Avastin. Why? It's a coexistence that PCV is there with the DME. We have seen a lot of other coexistence.
ICG was not evident of PCVs. ICG,
no, the ICG you showed a central polyp, no?
It was not increasing in intensity with the phases, sir. There was no increasing.
No. Actually, the polyp, unlike a CSR leak, it will not keep on increasing in size because polyp is a well-defined thing. The polyp usually appears in the around 1.5-2 minutes that time, and then it increases in intensity, but the size will not increase like a CSR leak. The RAP usually comes in very early phase. The leak comes very early at the beginning, immediately after injection. So that is the difference between RAP and polyp. But I think that was a polyp. Gopal, what do you say?
I was thinking that was not a polyp. But anyway, that I think we need to review those pictures later. But I thought it was not a polyp. And a second ICG also was done after initial 6 injections. And that also did not show any polyposis. But by the time initially, you can see that the fluorescent showed absolutely no lesion other than those microaneurysms. Later on, that CNVM pattern also came in.
It is actually,
he had some financial. I was thinking in terms of a PDT also, but there were some financial constraints about it, etc. So that is why. So now over 4 years, he has maintained 6/12 vision.
Yeah, that's a good result actually. To be frank, with the 2 diseases in the macula and maintaining 6/12 is reasonably very good.
Do you think aflibercept would have made a difference?
Yeah, that is actually, I will tell you the other line of action. Probably when there is a non-responsive PCV, I will do a OCTA, and if that is showing this typical network or something, I will go for aflibercept or PDT if it is avoidable. This is another line of action, but the patient can't afford, we can't do anything for that. So this is what for discussion's sake I am telling. That's all. Definitely, we will go for aflibercept in these cases.
Aflibercept definitely has more action on the pigment epithelial detachment, the sub-RPE fluid significantly reduced.
Huge PEDs collapse dramatically.
Collapse.
Yeah, all of us have seen that.
I had a patient who had almost 30 injections of Avastin, maintaining at the refraction was plus 4.5 always. The second I had got refraction was plus 4.5. After almost 30 injections of Avastin, I gave 2 aflibercepts after convincing the patient over so many years. And from 4.5, the refraction came down to plus 2. And it has been maintained over the last 8 years.
Yeah, that sometimes happens. Now, interestingly, in this, I had done this study on what happens to the VEGF levels. I was looking at the VEGF levels also. In this particular patient, VEGF level initially after the first injection, it fell down, but then it continued to be in that level over a period of time. So with anti-VEGF injections, over the first 6 anti-VEGF injections, the Usually, if it is 600, it will drop down to somewhere around 100. Okay, that is a drop in VEGF levels usually occur. But in this patient, it dropped down from 580, it dropped down to somewhere around 480, and it remains somewhere there throughout the 6 months. So again, maybe the activity is triggered of something other than VEGF also.
Yeah, maybe.
Can we move to the next case then?
Yes. Swati, this is
Yes,
not
sir.
AMD case, I think. So I told her to present some case. She got the, actually, Swati Haridas is our fellow. She did a very hard-working 15 minutes, 20 minutes drawing yesterday for a COVID positive patient, and today she has gone for quarantine.
Okay, so good evening. Am I audible to everyone?
Yeah.
Okay, so good evening, everyone. This is a case about a 28-year-old female who presented to us with a diminution of vision in the right eye since 2 weeks. And she gave a history of long-standing defective vision in the other eye for almost 3 years. Her presenting BCVA was 7.5 in the right eye with N6, and the left eye it was counting finger at 50 centimeter. Anterior segment examination in the right eye was quite normal, within normal limit, and the left eye showed a shallow anterior chamber with 360-degree posterior synecdoche and a cataractous lens with vascularization, which actually precluded the fundus view. The fundus picture of the right eye is shown here, the doctor's image, which shows a clear media with a pink colored disc with the blurred disc margins all over, and suggestive of subretinal fluid around the disc, suggestive of a disc edema. And nasal to fovea, you could see a wedge-shaped hypopigmented area with a wedge pointing towards the disc. And otherwise, the fundus was looking quite normal. The vessels were normal. Past history was like the long-standing diminution in vision in 3 years in the left eye was treated as a posterior uveitis, as a toxochorioretinitis elsewhere, and was treated with oral clindamycin and oral steroids for almost over 1 year, and finally she had to shift to Ayurvedic treatment. Although her manto was strongly positive at the initial visit at the other hospital, but her toxo IgG titers was high, and also her AC tap had shown a positive toxo. So maybe that's why they had started her on oral clinda and all. At our in the first visit at our hospital, the OCT done through the foveal section is demonstrated here, which shows a normal inner retinal and outer retinal layers in the area which is temporal to the fovea. But if you see at the area which is nasal to the fovea and between the disc, there is an area of increased hyperreflectivity of the inner retinal layers. Comparatively, the outer retina remains is looking normal, and some patchy Z loss can also be seen. Which was seen just the same in hyperreflectivity was seen above and below the disc also. So we went ahead with the fundus fluorescein angiogram for the patient. The early images showed a normal vasculature, but there was some area of a wedge-shaped hypofluorescence in the early images, just nasal to the fovea, and as well as just temporal to temporally. And in the late phases, the wedge-shaped hypofluorescence was remaining the same throughout all the phases, and the hypofluorescent patches in the temporal area had disappeared by that time, and there was a very significant disc leakage in the disc leakage in the late phase. So it was a case with disc leakage with occlusion. Is it a cilioretinal artery occlusion secondary to vasculitis? We had to get a rheumatology workup for her. So she came back to us after the rheumatology workup. In that time, her BCVA was remaining the same, but that hyperpigmented lesion had resolved and the disc edema had a little bit resolved. The whatever subretinal fluid was there that had got resolved, and the inner retinal reflectivity had decreased, and the inner retinal layers had almost fused together, which is usually seen in a vascular occlusion sequelae and just other OCT. And in the vasculitis workup, if you notice, they had looked into for the occlusive nature of the disease, and they had looked into Behçet, they had seen for sarcoidosis, and also other coagulation profile was also done for the patient. Finally, she was found to be positive for TB quantiferon, and homocysteine was found to be positive for her. Due to the homocysteine positivity, she was started on oral folic acid, and she was advised to consider ATT. with or without immunosuppression and oral steroid in case it worsens. So since the patient had a stable vision, we didn't really start her on oral ATT or any steroid. But 3 weeks later, 1 month later, she came back to us with a mild AC reaction, and the media was getting hazy. So we started her on topical steroids and cycloplegics, and straight away we went ahead for an oral ATT and oral steroids for her. But again, some 3 weeks later, she's coming to us with a drop in her vision to 612. And if you see clearly, you can see some lesion that is subretinal, likely to be starting developing temporally. So we had to go ahead with the investigations for her. We repeated the OCT, which showed a choroidal elevation, just temporal to the in the temporal area, and some subretinal fluid tracking down, and some suspicious contact sign, maybe, not sure. A choroidal elevation, well-defined lesion, kind of a mass-like lesion is seen over here. We had to repeat the DFA. And the earlier wedge-shaped hyperfluorescence, which was noted in the initial presentation, was not there. But the earlier hyperfluorescent area, which was there in the initial, which is seen in the initial phases of the FA, are later seen to have stippled hyperfluorescence and with minimal leakage. And all over the fundus is having a small vessel leakage from the capillary, or something like a small vessel vasculitis or something. And definite disc leakage was also persisting. So we were suspecting, is this a tubercular granuloma, or is it a drug-resistant TB, or is it a poor compliance to the ATT after all, or is it a paradoxical reaction? So we increased the dose of oral steroid to 60 milligram once daily, and tapered it slowly. In almost 3 weeks, her vision had improved. The OCT showed the choroidal thickness had dropped down, and she was symptomatically far better. And we again tapered the steroid slowly, and this is the follow-up OCTs, which showed the dropping down of the choroidal thickness, and the mass had started to decrease in size. This is 1 month later, she came with 6/6 N6 vision, and she was getting her ATT as well as her oral steroids in a tapering dose. And in 6 months, she is having 6/6 N6 in her right eye, and the lesion is not to be seen, almost not there. And although that outer retinal, inner retinal loss is there, otherwise she is fine. So maybe it's a case of just paradoxical reaction as a consequence of starting ATT. We're not sure, but it subsided well with the oral steroids, and patient was one-eyed, and we were happy with that.
Okay, you can stop sharing.
Yes,
I was thinking why that celioretinal occlusion happened. Do you see vascular occlusions in the second part is absolutely fine, that the choroidal granuloma, mass lesion responding to ATT, paradoxical reaction, everything is fine. Why did it initially had a vascular occlusion like picture? Gopal, any experience of vascular occlusion? That too celioretinal.
Not really in the setting of tuberculosis.
Yeah, that's what I don't know whether that was something.
But there are a lot of small vessel vasculitis also which occurred in a later fluorescent whenever the patient worsened with a paradoxical response. Probably there is some element of vasculitis within this particular. How did we lose the other eye?
No, I think he came, other eye was blind, no? The cataract and corneal vascularization.
When she came, it was already CF30, 50 centimeters.
For how many months or years?
1 year.
No, 3 years. Since 2016, she was under treatment in there, and then she came to us in 2019.
It's an autoimmune age group?
28 years.
Is it autoimmune age group?
28 years, huh?
It's 28 years, sir.
28 years. So I think it should be, we should have some underlying inflammatory pathology, but with the Manto of 40, whatever inflammatory pathology it is there, whatever immunosuppression you are giving, we have to give under cover of ATT only. That's very correct. There is no two opinions about it. But probably in this patient, I think, how long did you put the patient on steroids? From January 2020 to present, about 6 months?
Sir, no, like 3-4 months she was on steroids. It was slowly tapered off, and the rest of the 2 months she didn't have. She had only the ATT.
First 2 months she was on steroids, and then we stopped steroids.
4. Like it was started with 60 mg, and slowly we had stopped it.
Slowly,
Because initially,
I think 2-3 months before that lockdown, it was stopped, no?
No, only thing is, maybe if it is inflammatory and if she has, see, 3 years back, if she had a tuberculosis in the other eye and she lost the vision, and now 3 years later, this eye is a little, I think it must be an inflammatory disease. And
Okay,
so
sir.
I think because it's the second eye, it's quite prudent to keep the patient on long-term immunosuppression, alternate immunosuppression other than steroids.
Steroids.
This is what I think. Ramya wanted to ask something. Please unmute and ask Ramya.
Sir, in the first OCT, as you see, corresponding to the choroidal, the hypoperfusion that you were mentioning, there was a choroidal lesion. So could it be possible that it is a choroidal hypoperfusion that you're taking as a ciliary-retinal artery occlusion there? Because the ciliary-retinal artery seems to be perfused well.
No. That whitening, that OCT has whitening.
OCT has
occlusion.
retinitis. The retinal part.
It is not
the choroidal.
Yeah, it is
No,
a
if you
typical
see the-
seen in arterial occlusion, no? That whitening.
But
It can also be seen in retinitis as well.
No, once you see the below part, you can see the choroidal elevation there.
That is temporal, no? Temporal to the.
No. At the just below
The
the
beginning.
lesion that you were mentioning as a hyperreflective lesion, and corresponding to that tubercular granuloma has developed later on. You can just-
But tuberculosis will not cause retinitis, no? So we are again going off.
Tuberculosis will cause
No,
everything, Mahesh. It can cause anything, right? From
Yeah, it has started from the choroid, but then it has reached the retinal level. That is what I think, sir.
Then,
just see the OCT once more.
Then,
no. So Ramya, you feel that this is purely tubercular?
I think so, sir.
Yeah. No, otherwise it both cannot be connected, no? That is a young lady. Why should a cilio-retinal artery occlusion occur?
If you can just see the OCT once.
Just can you share once again, Swati?
Yes, sir.
The initial OCT.
Yeah, there is something underneath. Huh?
Sorry.
Same OCT which you were showing just now.
Yeah.
No. Before this. The second picture.
Second picture. There is something raised in that area. Next, the nasal
and
side.
in the same area, later on, he has developed a choroidal.
Yeah.
This is the initial. Sorry, this is the initial.
First slide you show. First slide you show. Go back. Then here that whitening, she is telling under that area there is a choroidal elevation, which is correct. Just next. Also, yeah. Stop.
No.
This is the initial one, no?
Yes, sir. But there is no choroidal elevation as such.
No, nasal to that area. Just point. Yeah, that area. But that is probably shadowing due to that.
Disc edema was also there.
Yeah,
at this point of time.
Edema was there. Hot disc was there.
Yeah, so that would be explainable on the basis of disc edema. Would it be?
The vascular occlusion, you mean?
The cilio-retinal type of vascular occlusion that Mahesh is telling is basically, can we go to that OCT? Yeah, so you are telling about the hyperreflectivity here, right?
Yes, sir.
The hyperreflectivity is there, but it can occur in all cases of retinitis. If you see a acute retinal necrosis also, this will be there. So but any retinitis, no cells. Okay, no cells.
Cells can be seen on the inner aspect of the retina. So this third scan, if you closely observe, you can see few cells.
Yeah, on the surface of the surface.
Clear in that picture. Anyway, that is
okay. That is all.
It is better to think that both are same, other than.
No, I definitely think that there is an inflammatory pathology, immunological pathology in this lady of 28 years with high MAN2. So what you did was you did cover for tuberculosis and gave her immunosuppression, and that suppressed her for the time being. But having lost the other eye, I think this is a this will also be something like that. And do you have any idea of how she lost the other eye? That will be a very important learning lesson for us for this eye.
Somewhere else.
Okay, so I think we need to go into that history, get to her old records and see, and then if it is some clue we will get for that.
Okay.
And I think that in the long run, maybe she may require immunosuppressions in the long run. Okay.
Okay, sir.
So, Thomas, can we?
Yeah. Can we conclude?
Yeah.
So thank you all. I take this opportunity to propose my vote of thanks. Dr. Anat Loewenstein, she gave us an insight into the use of the newer anti-VEGF brolusizumab and exhaustively covered the options which we have in management of wet AMD now. In her absence, I thank Professor Anat Loewenstein for the excellent talk and leading the discussion throughout. Dr. Aditya Sudhalka, Aditya also did a wonderful presentation laced with case presentations on his experience. Thank you, Aditya, for coming online and doing this presentation.
Sir, thank you very much for having me. It was an honor to present in front of such a focused audience.
Pooja and Swati turned up with good presentations, which had good discussions. Thank you, all three of you, Remia, Pooja, and Swati, for making this evening lively.
Thank you, sir.
Dr. Mahesh, he is the backbone of the Cochin Retina Group. Mahesh has been moderating this session. Thank you, Mahesh. Cochin Ophthalmic Club has been in the forefront of all academic activities. Dr. Sai Kumar, the president, and Dr. Gopal Pillai, the secretary, have been very active during this time of COVID and lockdown. And this presentation has also added one more feather to the already crowded cap of Cochin Ophthalmic Club. Thank you, Sai and Gopal. Novartis has brought us a new kid on the block. Let me take this opportunity to thank Novartis for bringing in this molecule and making this discussion happen. Thank you all for being online. Have a good evening. Thank you.
Thank you, sir. Very good evening to all. Thank you.
Okay. Gopal, bye.